On behalf of my co-authors, I would like to present the results from our study, The Impact of Indication for Cesarean on Blood Loss. Cesarean delivery is the most commonly performed major surgical procedure in the world. In addition, postpartum hemorrhage is the leading cause of maternal mortality worldwide. Historically, blood loss at the time of delivery was estimated using a general visual estimate. More recently, quantitative blood loss, or QBL, has been developed. QBL has been shown to be more effective and accurate than estimated blood loss, and as the use of QBL becomes more widespread, the establishment of normal ranges of QBL following cesarean delivery is essential if meaningful treatment protocols are to be developed. While risk factors for postpartum hemorrhage are well described, contemporary investigations into the impact of indication for cesarean delivery on quantitative blood loss are lacking. We sought to describe the average quantitative blood loss by indication of cesarean delivery and investigate whether there are clinically significant differences in quantitative blood loss and rates of postpartum hemorrhage and of serious postpartum hemorrhage based on the indication for cesarean delivery. We performed a retrospective cohort study of all singleton cesarean deliveries performed at a large academic hospital between November 2020 and December 2022 for whom QBL and indication for cesarean delivery were available. Cesarean deliveries were divided into primary and repeat procedures and then further subdivided into 7 indications: elective, labor arrest, fetal heart rate abnormalities, placenta previa, placenta accreta, malpresentation, and other. We found clinically significant and statistically significant differences in QBL based on the indication for cesarean delivery as displayed here in this violin plot. Our data support several important conclusions. Quantitative blood loss, mean, median, and standard deviation values have been established for cesarean delivery by indication in a large contemporary cohort of patients. 30% of all primary cesareans and 14% of all repeat cesareans were associated with a postpartum hemorrhage of greater than 1,000 cc's. Both quantitative blood loss and rates of blood loss greater than 1,500 cc's differ to a statistically significant degree based on the indication for cesarean. Our findings that cesareans performed for placenta accreta, which in most cases will actually be cesarean hysterectomies, have the highest blood loss is not surprising. However, we find it remarkable that the actual mean blood loss in our institution for women undergoing planned repeat cesarean delivery and hysterectomy for placenta accreta is less than 400 cc's more than that seen in primary cesareans for labor arrest. We believe this is due to the specialized surgical approach to placenta accreta pioneered in our institution. Our study highlights the significant influence that the context in which a cesarean is performed has on QBL and the associated risk of postpartum hemorrhage. Together, these data demonstrate the need to include indication into postpartum risk stratifications and explore a more detailed strategy in preoperative preparation, emphasizing the distinct risks tied to different cesarean indications. Additionally, our results suggest the need to reassess surgical methods to decrease the chances of maternal morbidity and mortality due to hemorrhage.